Is there more risk of extrusion in those cases?
I mean, in theory, yes. I've done it twice already,
Okay.
and both patients have done very well. Of course, for those type of patients, you are not going to oversize their
Okay.
implant. Make sure. I mean, I will not place a malleable implant on those patients because again, there is a higher risk of extrusion and erosion on guys who have malleable implants. So I would be very conservative. But I mean, you can get a big implant there and they should be okay. Probably the third pearl would be if for any reason you need to wait longer to get the implant. And this is probably the best advice I can give everyone who's listened to this: vacuum erection device during the pre-op phase. Using a vacuum pump every day, twice a day, will create negative pressure inside the corporal bodies, bring venous blood, and it will keep the corporal space open. Aggressive VED therapy is key to set yourself up for success with these patients. It will help dilate the tissues and allow you to maximize the size of the implant. Pearl number 4, again, come ready to your surgery. Be ready to be bringing in all your drilling tools. You will be drilling inside those corpora to break down that fibrosis. Make sure you have all the instruments you might need. For example, one of the ones that I use the most is the Rosselló Carrion cavernotomes. There's people who use the Euromix cavernotomes. I also use medicine-bound scissors. There's also a video about this, by the way, on YouTube.
Okay, good.
So medicine-bound scissors. There's people who use reverse cutting scissors. There's a special dilator called the I think it's the dilamescent. Yeah, dilamescent dilator. This one comes with a blunt tip that you can use for straightforward cases, and it also comes in with a pointed tip. I don't use that. I see it and it makes me cringe. I feel like I'm in a medieval movie, but again, it's something that can definitely be handy in some cases. And the last pro would be if you are unable to dilate through the proximal incision, be ready to either use a counter incision. It's very common for these cases, or be ready to just extend your incision. I mean, if you're going penoscrotal, just extend your incision distally and your corporotomies distally in order to properly dilate to avoid distal injury. The one thing you don't want to do is be forcefully dilating because you will either injure the urethra, you will cross over, or you will just perforate through the side. Again, these are things that I've seen, and you want to make sure that you set up yourself up for success. So again, these are going to be long, tough cases. Just be ready to do a little bit of everything.
Yeah, and I guess if you make the decision to go in and you see something you don't expect, it's okay to close and send it to Jonathan.
I've actually had those. I remember, I will never
Yeah,
forget when I was in fellowship, there was a local surgeon who wasn't able to dilate distally, and the guy just he put in a very small, like a 15 centimeter implant, and the guy probably needed like 24 centimeters or something.
Oh yeah.
And I'm like, don't do that. I mean, if you can't dilate, just close him up.
Okay.
And just refer him to somebody who will be able to take care of this guy. Again, you don't have to operate on everyone. It is not a sign of weakness to ask for help.
Exactly.
And just do the right thing for the patient.